Late stage patients, late metastatic stage 4 patients are still in some situations able to be cured with the new therapies we have. I have this amazing woman who I've been treating for 5 years. She has metastatic colon cancer.
Hello, and welcome to eShadowing. I hope you are excited to be here to talk to my good friend, Dr. Shikha Jain, who is a hematologist oncologist. We're going to have a great conversation about her specialty. Let me see if I can find her in the list. I see her. No, listen to me. Got too many people joining at once. Nope. Shikha, can you raise your hand? Did you do that? Oh, look at that. Oh, look at that. Thank you. Promote to panelist. Let's rock and roll. As we're getting Dr. Jain on, let me know where you are watching from and if you are interested in Heme Onc, because that is our conversation today. Dr. Shikha Jain, who's from Chicago? Bree's from Chicago. Hi, Shikha.
Hi, hold on 1 second. I'm in our home office right now,
Yes.
and I realized my sons were charging their Spider-Man web shooter, and it is wrapped up around my chair somehow.
You're stuck in Spidey's web.
Totally stuck in Spidey's web, but I am here. I am so ready. All right, let me get my camera on.
I love it. Is this the famous home studio where you do all of your TV appearances?
It is. It's a little bit messy right now, but you'll see.
Here's what I found.
I've got, I just moved, literally, I just shoved you. I won't show you what's over here. I literally just shoved a bunch of children's things because my daughter's been using this area for homework, and then my son's web shooter. So yeah.
Yes.
So this is what it normally looks like. Very nice and pretty. You don't see all the mess that's over here.
Yeah, no, that's all that matters. That's why I love the camera point of view is like this, and then all of the clutter is away. Like, I don't even want to see.
Well, I'll tell you, the sad thing is, because I have a computer screen here, my husband once watched one of my TV interviews, and he said, you can see the entire mess in the I was like, no one's paying attention to that. It's fine.
Oh, no. Well, Dr. Shikha Jain, I'm excited to talk with you again about hematology and oncology. You have, I think, seemingly become much more famous since our last talk. And so I will take all the credit for that. You're welcome.
100%.
Let's talk about Heme Onc. So we're live now. Last time we talked for our specialty stories recording, that was pre-recorded. We were just chit-chatting. But we're live, and so students can interact with us. We can maybe do a kind of a simple case potential presentation and run it by students, see what they want to do. But Heme Onc, what is that?
Yeah, so, first of all, I am not famous, so please do not listen to Ryan. I am not famous at all. But any of my success, I 100% attribute to you. So Heme Onc. So I am triple board certified in internal medicine, hematology, and oncology. So internal medicine is adult medicine.
Slacker.
I know. People ask me why I'm maintaining all 3 of my certifications, even though I only practice oncology. And honest to God, this is the reason. My husband is double board certified. My father is double board certified, and pretty soon my husband's only going to be single board certified because he's not maintaining internal medicine. And I said, I'm going to maintain my triple board certification specifically so I can lord it over all of you. That is literally
hold it over their head.
Exactly. So I first, after medical school, I first did an internal medicine residency, which was 3 years. And then I actually took a kind of circuitous route. My husband and I decided to get married the year after residency, and we took a year off, and I worked as a locum tenens physician in New Zealand for a year with him. And then I came back, started my fellowship, and I did a hematology and oncology fellowship, which is a total of 3 years. You can do just hematology or just oncology at certain institutions. I chose to do a combined, and then I have board certifications in internal medicine, hematology, and oncology.
Yeah.
Hematology is a study and the treatment of blood disorders and blood diseases. Some of them are cancers, some of them are not. So things like everything from leukemias to sickle cell disease to anemia is in the space of hematology. Then oncology is solid tumors. So things like pancreatic cancer, lung cancer, breast cancer. I also decided, because I really was fascinated by GI oncology, to subspecialize. It doesn't require any extra training. It's more just a decision to really see predominantly GI oncology patients. So now I see predominantly patients that have things like colon cancer, pancreatic cancer, and more specifically, I see a lot of neuroendocrine tumors.
Wow. That's a lot. That's a lot. So triple board certified, for someone watching this who may not be aware, right? The tests that you have to continue to take throughout the years and pay lots of money for. You don't really use your internal medicine or hematology. It sounds like your main focus day in and day out is oncology.
It is, but I would say that I use my internal medicine and hematology in oncology because, especially when you're on the inpatient service. So for those of you who don't know, most oncology patients are seen in the clinic. So you see them for, clinic visits, for chemotherapy visits, for surveillance visits. But there is a component of oncology where people get admitted to the hospital, where they have small bowel obstructions or they have pneumonia. And so as an academic attending, I actually am on the inpatient service pretty regularly as well. And so my internal medicine really serves me well there because, for example, I'm on service right now and I have a patient who we're dealing with congestive heart failure, another patient where we're dealing with pneumonia, another patient we're dealing with kidney failure. So while I don't prescribe antihypertensive drugs or manage people's diabetes as much as I would if I was a general internist, there's still a lot of internal medicine in oncology. And then the nice thing is, because I'm certified in hematology, when my chemo patients are having low blood counts, I can work them up pretty extensively before needing to send them to a hematologist. So it saves them a visit. I mean, patients don't come to me anymore specifically for blood disorders. If they did, I could probably see them, but I would probably recommend they see somebody who's actually doing that every day. But it's nice because I have that triple board certification, I can still, with some confidence, treat some of those more common internal medicine and hematologic issues.
Got it. So what percentage do you think of practicing, or maybe the question is, what percentage of residents now going through, or actually fellows going through their fellowship, are just hematology, just oncology, or combined? Do you know those numbers?
So I don't know the exact numbers, but I would say the majority of people who go through are both hematology and oncology when they go through training, because most fellowships are combined programs.
Okay.
There are places like the NIH that have, like I said, a specific hematology or specific oncology. And there are people who go through the entire combined fellowship and then decide they only want to do board certification in one. For example, a lot of my oncology colleagues went through heme and onc fellowship, but then decided I'm only going to be an oncologist, so I'm not going to take the heme boards. So you don't have to take the boards, especially if you're going into a field that's super specialized. Like right now, I'm recertifying internal medicine. I really don't need to do that. Another reason, other than holding it over my husband and my dad, the other reason I am doing it is for leadership positions. It's been recommended to me, like if I ever wanted to be like the chair of the Department of Medicine, or if I wanted to have a leadership role in the Department of Medicine, which is a possibility, sometimes it helps to maintain your internal medicine board certification.
You're part of the tribe.
Say it again.
You're part of the tribe.
Exactly. So, but it kind of leaves options open for me. So for me, it's something where, as much as I love to hold it over my family, it's also something that might help me with future career perspectives.
That makes sense. I would love to know, and I don't think we got into this in our previous discussion. What is the history of why hematology and oncology are together as one? Because, I mean, at least nowadays, we don't see that anywhere. That's like I don't even know what that's like. I couldn't even compare like two other specialties being married together.
It's interesting that you asked that, because I used to wonder that as well. And it took me going to fellowship to understand why. There is so much overlap. So hematology also deals with a lot of blood cancers.
Yeah.
And now, actually, in 2023, it's fascinating because there's actually some treatments that you treat for solid tumors and you treat for liquid tumors for like blood cancers. So all of these new immunotherapy agents that are out there that activate your own immune system to fight the cancer, there's a lot of overlap between solid tumors and blood tumors that the same treatments are utilized for both. So there's a lot of overlap in what we see. A lot of times a patient will come to a hemonc doc and say, I have a mass. And we don't know if it's a lymphoma or a colon cancer. So having that training to know how to navigate a diagnosis once you see the initial presentation is a really important thing to know, especially when you're looking at all of these different types of cancers.
Got it. Is cancer becoming more common, or just with media and webs and maybe better diagnostic tools, we're just finding it more?
So I think it's a multitude of factors. So number one, medicine has advanced and changed so much in the last 100 years. And we are finding a lot more cancers because our imaging modalities, our screening modalities, they're all very much more sensitive than they were before. I mean, before people would die and no one would know why, right? Now you can do an autopsy and you can do imaging pre diagnosis. You do screening tests like colonoscopies and mammograms. So I think we're capturing a lot more of these cancers because of modern medicine. I also think our diet has evolved over the last 100 years. Our lifestyles have evolved. We're seeing more obesity now. We're seeing the impacts of people in the 60s, 70s, and 80s going out without sunscreen. So we're seeing a lot of skin cancers from damage that was done back 30, 40 years ago. We're seeing more people eating more processed foods. So there's a lot of different reasons for why we're seeing so much more cancer. Overall, I think in some cancers, we're seeing the incidence of late stage cancers going down because of our screening modalities like colon cancer and breast cancer, but we're capturing a lot more cancers in general. And another thing I should state, we're actually seeing a lot more of young people diagnosed with cancer. Like as a GI oncologist, I've seen a lot of young colon cancer patients, especially over the last couple of years, it's really sad. And it's because it's before the age where they're technically supposed to be getting screened. Young people usually think, oh, I'm having these symptoms, I'm fine, I'll see the doctor in 6 months. And by the time they go in 6 months, the cancer has progressed.
Is that Oscar Meyer's fault? Like, is that are those too many cancer sticks that we're eating? Like, what's like,
so I think there's
disclaimer, I'm not blaming Oscar Meyer. Don't come after me.
I think that it's a multifactorial issue. I think that there was the age of the TV dinners and the age of dual working families. And instead of having, fresh food from the market, now you're having, TV dinners and you're having frozen food. And again, we do it in my house. I'm not saying that we don't eat that type of stuff in our house, but there was a huge shift 50 years ago to more convenience. And I think a lot of that, we didn't know the types of long-term impacts some of those decisions would have. And now they're a very much an integral part of our culture. So there's a lot of data out there showing that our dietary habits, our exercise habits, our sleep habits can all be impacting our overall health. And then at the end of the day, who knows, the stuff we're discovering now that we're saying is a really exciting intervention or invention may in 50 years prove to be very dangerous. So I think it's just as we evolve as a society, some of the man-made artificial things that we introduce into our lifestyles and our lives may have long-term effects that we do not necessarily know just yet.
Yeah, but we're not talking about the COVID vaccine. We know that vaccines have a very short life.
Good. Everybody should get the COVID vaccine. And that is not what I'm talking about. Vaccines do not cause long-term complications. All the vaccines that have ever been studied, if anything, problems right away. If they don't cause problems right away, then they don't cause long-term problems. So we are not talking about the COVID vaccine. I'm telling everybody, if you're listening, you should get it. If you've not gotten it yet, and you should get your booster.
All I heard was you're like, who knows what we're making up that's going to hurt us later. And I just hear the anti-vax people are like, I got you.
You know, they love to come after me. So
no. So what is a big misconception about oncology that you're fighting amongst your well-educated peers, your fellows, your residents out there?
I could write a book if I started telling you about all the misconceptions, but I think one of the biggest misconceptions about oncology, which I did actually write a book chapter that's coming out in April in a book that's for sale on Amazon. People think that oncology is really sad. And even when I went into it, my dad's a physician. And when I decided I wanted to go into hemonc, he said, why? That is so depressing. And I said, but it's not. I said, oncology can be absolutely very sad. And we deal with life and death on a daily basis. It can be devastating and it can be hard and it can be emotionally draining. But it can also be incredibly uplifting. We get the honor of being a part of people's lives, sometimes in the hardest part of their life, whether it's dealing with a new diagnosis of cancer or transitioning to hospice. I mean, I am so blessed to be in this field that I'm in. I feel so lucky because I've been able to impact people's lives and help people in ways that I otherwise would not have been able to do in another field. I think that it really provides a lot of long-term opportunities to make connections with patients. And the biggest thing for me about hemonc, so when I was a kid and I used to watch my dad see his patients, like even as a surgeon, he had long-term relationships with the patients. Like we'd be in the grocery store and someone would be like, Dr. Jain, how are you doing? You saved my mom's foot. We love you. And all these things. And as I went through med school and residency, I noticed that healthcare was moving away from that. Healthcare was moving towards shift work, and we're moving towards, signing out and saying, oh, it's not my patient, and it's not the physician's fault. It's not the trainee's fault. It's just our healthcare system is evolving in many ways that I don't think is healthy for the healthcare system or our patients. But the thing that I think is so special about hemonc is you are almost forced to have long-term relationships with these patients. And long-term could be 6 weeks, it could be 6 months, it could be 6 years. But the amount of time you get with these patients and the way you really impact their care, I don't see that in many other specialties. And for me, it's such an honor to be able to do that and to be able to help families and patients walk through sometimes what's the most difficult part of their lives. I mean, I've gotten more thank you cards from patients' families after they've passed saying, my dad loved you. He loved coming to see you. We understand that, this was his time, but we so appreciate you helping us navigate the hospice system or navigate like end of life care, having those tough discussions. To me, that's just as important as curing somebody with cancer, because we're all going to die someday. Like what do they say? There's the only things that are inevitable are taxes and death or something like that. There's some phrase like that. And I mean, that's until we figure out a way to live forever, that's an inevitability. If I can help people and their families navigate that part of their life, to me, that's something I'm very fortunate to be able to do.
Yeah. Do you live in a state? I think you're in Illinois, if I remember correctly. Do they have right to die laws in Illinois?
So it's very murky. It's very murky, and it depends on who you talk to, and it depends on where they're getting care.
Okay.
And I probably will not go on record to talk about it because I don't want to get in trouble in case anybody watches this. But I know people are watching this in case anybody watches this who I work with. But I will say that there are more options in states like Illinois than there are in some other states.
Yeah, that's good. We just navigated that. My mom's husband just passed from pancreatic cancer, and we're in Colorado where we have a right to die law here. And so he went to the doc and said, it's my time, and got his medications, and he was going downhill pretty fast. But he took his meds, and a couple hours later, passed peacefully. I hope everyone understands just how powerful that ability for someone to go out on their own terms is. I think it's wonderful.
Well, and I'll read you the official statement because I pulled it up because don't want to be misquoted. This is literally what it says about, is there a right to die law in Illinois, which is why I did not specifically state. Physician-assisted suicide is not a legal option in Illinois. However, there are options for Illinoisans who wish to self-determine their end-of-life care through the execution of advanced directives. So that is why there are options that you can walk through with your physician. But it's a very difficult situation, because you see patients who are miserable and just struggling, and that they have a metastatic cancer, they have a terminal disease, and you want to do everything you can to help them. And so the question becomes, in many of these states, how can I actually help them?
Yeah. What is your biggest piece of advice for someone coming up? We have 125 students here, to start to be able to embrace those tough conversations, to be proficient at them and get good at them. Nobody will ever enjoy them, but to be able to have really powerful, tough conversations with patients and their families.
Practice, get feedback from someone you trust. Have these conversations in front of your attending or in front of your senior resident or fellow, and get feedback, because a lot of it is emotional intelligence. A lot of it is reading cues. If somebody starts crying, get a tissue, know when to pat somebody on the knee and when not to. I'll give you a perfect example. I had this fellow who I worked with, who is a pulmonary critical care fellow. He's one of my favorite human beings in the entire world, one of the most empathic, smartest, brilliant people I've ever met. He was my fellow when I was in the ICU, and this very sweet old woman passed away. And it had been a really long night. He was really stressed. He was really overwhelmed. Like, all these people had coded at the same time. And he ran out of the room and said she died, not realizing her entire family was standing outside the room. He came out to tell us, but he was so distraught by everything that was happening. He just came out and he was like, she died.
Yeah.
Not empathic. And the family was shocked, and it turned into a whole hullabaloo, and the family was so upset and they're all wailing. But he handled it really well. So he made a mistake, but then, because he had such high emotional intelligence, he took them to a private room, he sat them down, he talked to them, he apologized, and then a whole conversation, and turned a very negative initial telling of bad news into a positive. So find people who do it well and shadow them, follow them, ask their advice. But the most important thing is listen. When you're talking, when you're a doctor, I know what's right. This is what you need to do. This is how I fix you. That's not what people need to hear. They don't want to hear, I am telling you, you should enroll in hospice. What they want to hear is, here are all the reasons why I think hospice might be the right way to go. Let's talk about what your fears or concerns are. What do you understand about the disease or about hospice? A lot of times we are talking here and the patient is here, or we're talking here and the patient's here. So you have to always ask them questions. What do they understand? What is their understanding of the disease, of the diagnosis, of the prognosis? And use simple words. So when I talk to patients, I don't use complicated medical words, even if they're physicians. Like my physician patients and my physician, when they're a family member, I will use maybe a few more higher level words, but for the most part, I break it down the way I talk to my kids. Yeah. And I do that because when you're hearing bad news, everything goes out of your head. One of my friends was admitted to the neuro ICU, my best friend from medical school. I love her dearly. And I showed up, and the attending happened to be one of my very dear friends. And he stood next to me and he showed me her brain MRI. And he talked me through this was her permission, obviously, her and her husband's permission, walked me through everything. I could not recite. My husband called and was like, what happened? I was like, I have no idea. And he was like, he said he walked you through the whole MRI. And I was like, she had a stroke. And he was like, but he said he walked. I was like, I literally can draw you the picture of what I saw. I have no idea. I couldn't describe it. So you need to make sure you ask people where they're coming from, because that is, any conversation you have is going to be useless if you don't understand where they're coming from.
It's so powerful. I don't understand why we don't do that in regular life as well. It's such a powerful tool. And I always talk about it. I have this discussion a lot with students because I'll do mock interviews with them. and we'll have a couple medical scenarios or something, and they'll start talking to me. I'm like, did you even understand like where my point of view was or what my understanding was? And I always bring it back to empathy, right? At the very end of the day, empathy is understanding where that other person is. And a simple question like, what do you understand about X is just so powerful. Talk about, if you can, the role of other people that you're working with. So as an oncologist, there are surgeons and other healthcare members, other specialists out there who are interacting with you, interacting with your patients. What does that look like on a day-to-day basis?
Yeah, so cancer care is multidisciplinary care. So what that means is I am an oncologist, but I rely on my surgeons, on my radiation oncologists, on my pathologists, on my radiologists, on my nuclear medicine specialist. We cannot treat a patient in a vacuum. So every week we have a tumor board where all of the experts from all the different fields come together and talk about patients. And I say, this is the chemo I want to give. The surgeons say, this is what I want to do surgery. And then we come up with a plan. We say, okay, well, the standard of care is we do chemo first. 4 weeks later, we do imaging. 4 weeks later, we do surgery. Let's get it on the books. And then I communicate with the surgeon. So I'll text them and be like, hey, Mr. Jones is finishing chemo next week. When do you want to see him? When do you want scans? Or they'll text me, hey, like one of my favorite surgeons will call me and he'll be like, I'm in the OR. This is what I'm seeing. What do you want me to do? And my response is usually, I don't know. You're the surgeon. What do you want to do? And then we'll, he'll tell me, well, this is what I'm thinking. And we have conversations. So it's very much, a multidisciplinary collaborative approach, because without that, we can't have comprehensive cancer care.
Yeah. I I was listening to a podcast where non-medical people and someone I respect, a reporter, was like, oh, the pharmaceutical industry doesn't care about cures. They don't want to cure anybody. They just want to collect all their money when people are sick. And the first thing I thought of, I think, was the conversation I had with you of how much chemotherapy has changed the game with the new immunotherapies, more individualized therapies where we're sequencing what the cancer is and developing stuff. How close are we to getting really even more powerful chemotherapies of where a cancer diagnosis, even potentially late stage, is not as bad as it has been in the past?
So here's what I'm going to tell you, because I get asked this all the time. When are we going to cure cancer? And I tell them we're curing cancer every day.
Yeah.
Not only are we curing cancer every day, late stage patients, late metastatic stage 4 patients are still in some situations able to be cured with the new therapies we have. I have this amazing woman who I've been treating for 5 years. She has metastatic colon cancer. And she texts me. I don't give my cell phone number out to patients typically. She is one patient who has my cell phone number because she texts me her travel photos. In between her chemos, she will text me and be like, I just climbed a mountain. This is because of you. I just ran a 5K. This is because of you. Look at my nephew. I got to go to his musical performance because of you. And she was told she was going to die 6 months in. I have seen people live long, healthy lives with metastatic cancer. There's a lot of cancers now that we are at the point where you can treat them almost like a chronic illness. That being said, there are a lot of cancers that you can't. Pancreatic cancer is still notoriously difficult to treat and cure. So to answer your question, we are seeing advances in oncology care faster now than we ever have before. I mean, from the time I was a fellow to now, the advances have been astronomical. So I'm forever excited about these advances because we're now seeing combinations of immunotherapy and chemotherapy together. We're seeing combinations of surgery and immunotherapy. There's so many different permutations utilizing the drugs we already know. And then these new drugs that are coming out, there's so many opportunities to do really innovative stuff with them. I anticipate that by the time you and I are ready to retire, the cancer kind of landscape is going to look totally different than it does right now.
Very, very cool. Do you think we'll have, I love technology. I'm a huge tech nerd. I've in the past, I don't have diabetes, but I've signed up and received continuous glucose monitors because my dad was a type 1 diabetic. And I'm like, I just want to check my sugar. And it's just really cool to have a device on your body that I can scan with my phone. Do you think we're all going to have some sort of implant that is constantly monitoring blood and going, uh-oh, that looks like a bone tumor cell floating around?
Honestly, God, I hope not. That would
No?
provide so much stress for me. And this is what I would say. So our bodies are designed to destroy bad things that enter them.
Yep.
Our bodies, like the immune hypothesis is the reason immunotherapy works is because for years it was hypothesized that we are all creating cancer cells in our body right now. Our cells mutate, period. They just mutate. That's what cells do. But our body has checkpoints like our immune system to identify these mutations and then destroy them. A cancer happens when one of those mutations happens and
that darn P53.
P53. And then that mutation gets out of control and the immune system for some reason didn't catch it. So the immunotherapy activates the immune system to attack it. My concern is if we get a scanner like that, every time your body makes an abnormal cell, are you going to be running to the doctor asking for a full body scan? I mean, I told you my husband's a gastroenterologist. He wants me to get a full body scan like every year because we see such horrible things. He wanted me to get my colonoscopy and my upper endoscopy when I was like in my early 30s. And I did it because he was so convinced that I had colon cancer when I had zero symptoms. I was a stressed out fellow. And he was like, you need these scans. And because he was a fellow and he was seeing horrible things. I mean, I think there is a line that we need to be careful we don't jump over, because we can all become hypochondriacs. We can all become, if we are constantly thinking there is something wrong with our body, if we're constantly dinging with a little bell on your arm saying, oh, your blood sugar went one number. I mean, it's the same thing right now with my chart, for example. So for those of you who don't know, there was a law that went into place, I think a couple years ago, where
terrible law.
things that like your lab reports are released, all your records are released immediately to you.
Yeah.
Oftentimes you see your reports before patients do. And so when that happens, I have patients who are contacting me saying, I have a number that's a little bit above my normal. Am I dying? This BUN, why is it 28? It's supposed to be 25. And things that are not clinically significant, patients are constantly contacting us worried with things that they shouldn't be worried about. So I get a little nervous if we get those scanners and put them into the general population, because one, it's going to breed hysteria if it's not done properly. Two, I think it's going to result in a lot more medical interventions that are necessary. I mean, you scan enough people and you're going to find a nodule or a node or things like that. So
incidentalomas.
Yes, exactly. So I would be very concerned about it. I mean, maybe it's going to be amazing technology and I'll be eating my words. And in 5 years, you're going to bring me back and be like, look at my scanner. And I might have one too, who knows? But for now, I think that it would be a little scary.
Yeah. So what is a typical patient process interaction with you? How do they get to you? Are they coming to you going, here's my cancer diagnosis, help me? Are they coming with symptoms and you're trying to figure stuff out? What does that process look like?
So I get a lot of variation in how the visits go. So it could be somebody comes in with a new diagnosis that they have no idea. And they've just been told to come see an oncologist. They don't know what an oncologist is. They show up and I say, you have, colon cancer, and they had no idea. Most of the time when people get to me, they know that they had a cancer diagnosis, but they may not know the stage. They may not know the treatment plan. I also get patients who come to me as a second opinion, where they come and they've been diagnosed, they've been treated, but they want another opinion, or they've been diagnosed and they just want to see someone else. So it's a variety of different ways. I have sometimes patients, like I have a physician at the hospital who texted me today that her friend wants to see me because nobody can figure out what's going on. And they think that she might have a GI malignancy, but nobody can tell. So they're sending her to me so I can evaluate her. So patients come to me in all different ways. There's a Facebook group of colon cancer, patients with colon cancer, and I've had a bunch of patients come to me from that group because they all know each other. And so they'll come and they'll be like, oh, Mary Lou recommended me. And I can't say, oh, I know who Mary Lou is because of HIPAA, but I'll be like, oh, really? That's great. So I have like a cohort of right now 6 women who are all from that same Facebook group who all referred each other to come to me. So there's a variety of different ways that I get patients.
Yeah. Interesting. Okay. For the students watching, if you want to come on and ask some questions, you can go and raise your hand and I'll unmute you. Talk about the sad stuff. When a patient dies, how do you avoid bringing that home? Or is that impossible?
It's hard, but so my husband cannot handle death and dying. He can't. That's why he went into GI. He does not do well with it. He gets very emotional. And even when I talk about my patient cases to him, I try not to talk about them too much to him because emotionally, he cannot handle it. Like it makes him very upset. He's a very sensitive person and he thinks of it as, what if this was my wife, or this was my mom, or this was my dad? And that's how he equates it. So I do everything I can to not bring it home, partially because I would end up consoling him if I told him what was happening. But there are times when I need to talk about it and I need an outlet. And sometimes it's him. Sometimes I talk about it with friends or colleagues or other people who understand. But for me, it's a little bit about compartmentalization, because at the end of the day, I'm a mom. I have 3 young kids who one was just knocking on the door and I just waved them out. So hopefully you didn't see them. I have 3 young kids. My parents are still alive and I'm very close with them. Thank God they live close and they help us out a lot. My in-laws are still alive. So I have a very large family, and I try really hard not to put myself in the position of every patient, because it's very easy, especially when you're getting to an age where the patients are the same age as you, or the patients are the same age as your parents. So I think compartmentalization is really important. Like, you need to be empathic, you need to be there for your patients, and you need to care. When you go home, you need to be present where you are. You need to think about, like, I've always been taught to be appreciative of your life and of your family and of your friends and what you have. And so to me, it gives me an even bigger appreciation for what I have in my life and how fortunate I am to have, a healthy family, to have, just the life that I have. So I think it's compartmentalization, but it takes time. It's hard to do. I've tried many times with patients. I've cried after going home. A dear patient who I was taking care of for 4 years, who, when she came to me, she was like, my doctor said I have 3 months to live. You need to fix me. And I managed to keep her alive for 4 years. We ended up she wrote a chapter for a book that I'm working on. She wrote a chapter with me before she died. And she said, I want you to publish this one day. I went to her house when she went on hospice, and I visited her in the middle of the pandemic because I promised her if she ever went on hospice, I would come to her house. So I went in my N95 and my face shield, but you have to compartmentalize, because if you don't, being a doctor in general, whether it's hem-onc or another field, it can suck the emotional life out of you. You have to learn how to separate emotionally your life at your job and your life at home to a certain extent.
Yes or no, according to the rules of Dr. Shikha Jain, is it okay to cry with patients?
Yes, 100%, 1000%. I used to be told that as a physician, you need to maintain your professionalism. You shouldn't share stuff about yourself. You shouldn't share stuff about your life. That is garbage. Yeah. That is absolute. I'm telling you this today. You can take me to the bank. You can write this down, quote me. You are a human being. You are not a robot. You are a human being. You are a doctor, but you are a human being first. My patients who have been with me for more than any patient who's seen me around Halloween knows my entire family goes nuts over Halloween, and we do a family costume every year. So my patients who are with me for multiple years, every year, November 1st, Dr. Jane, where are your kids' Halloween pictures? And my Halloween pictures, so we all dress up. I share my life to whatever extent I feel comfortable. And I share my emotions with my patients because that little bit of vulnerability and a little bit of humanity connects me even more to my patients. They know that I am just not looking at them as a rubric or as statistics or as guidelines. I'm looking at them as somebody's mom, as somebody's dad, as somebody's grandma. And that, I think, is what makes a truly good physician. I will die on this hill. Like, you as a physician, it is your job to make your patients feel as comfortable as you. And there's some patients who don't want to hear anything about me. There are some patients who I don't share anything about me. There's some patients who just want you to come in and say, this is what I want. And that's also fine. You need to figure out what your style is and how you relate to certain patients. I tell a lot of people that when you're looking for an oncologist, it's a lot like dating. There are some people who I am totally their jam. I am the oncologist for them, and they are super happy to see me. There are some patients who I am sure have come to me and been like, this lady is nuts. Like, I don't want to see her. I need an old white guy who's going to come in and tell me this is what I need, and this is how I need to be treated. And I don't want to hear about her kids, and I don't want to hear about, like, there's people like that too. And that's totally fine. I don't take it personally because it's like dating. Cancer care is such an intimate space. You need to be with an oncologist who you trust. And at the end of the day, you share as much as you feel comfortable. My husband doesn't share much with his patients. He shares some things, but he doesn't really share much. And that's his style. And that's fine. His patients love him. Like, I know he sees like heads of hospitals, all these like big name people go to see him because he's really good at his job. And he's a great gastroenterologist, but he doesn't practice the way I do. And that's okay. You have to figure out your style. But it is 100% okay for you to cry in front of a patient. That being said, the patient should not have to comfort you. So if you're crying with a patient, you cannot become hysterical. You cannot be the person who all of a sudden the patient's like, oh my God, Dr. Jane's like having a meltdown. Like, let me take care of her. Like, I had a patient who, I have twins, and this was a guy who, him and his brother, they were twins, and his brother had donated a part of his liver to him. And when the patient was dying, his brother was there and they were crying and his wife was crying. Everybody was crying. So I cried with them because I'd been taking care of him for a while. He was young. His brother had donated a part of his liver and they reminded me of my kids. You know, I've got twins. I've got twin boys. So there's nothing wrong with crying as long as you don't become the center of attention.
Love it. Love it. And I agree 1,000%. Huh. Elise, well, I promoted you to panelist. I shouldn't have done that, but oh, welcome to the panel. Hello, Elise.
Hi, you can demote me. I'm so sorry.
I will later. You can talk now.
All right, thank you so much.
Yeah.
I had two questions for you, Dr. Jain. The first was, when did you know that oncology, hematology oncology was your direction? Like, did you know when you started medical school, or were you like most med students where you changed your mind halfway through a few times? And what is the process for approaching not just hematology oncology? I know you already covered that, but if you wanted to go into a subspecialty of it, like you're in GI, right?
Yep.
And I'm interested in pediatrics. So like, how does that work, if you wouldn't mind? Thank you so much.
Yeah, of course. So first of all, I did not know I wanted to be a hemonc doc. I actually, when I was a med student, said I would never be an oncologist. And I came into med school thinking I was going to be a pediatrician. Then I thought I was going to be a vascular surgeon like my dad, because I went to the OR with him and his partners and I had an amazing time and I love surgery. Then I thought I was going to be a cardiologist. Then I thought I was going to be a pulmonologist. So med school, I went through then I thought I was going to be a neurologist. So I went through a lot of different fields in medical school. I realized that I wanted to do internal medicine because I did not know what the heck I wanted to do with my life. And I figured internal medicine was a really good way for me to decide, okay, I can now subspecialize into something else. When I did internal medicine, I started off thinking I was going to be a cardiologist. That was my plan. I was going to go into cardiology. Then I did pulmonary critical care and I loved pulmonary critical care. And I was like, I want to be an ICU doc. I had a mentor. She told me, you have to do pulm critical care. You are amazing at this. And then I did my hemonc rotations. And I just felt like I was in the right place. Like I connected with the patients. I saw that long-term relationship, which to me is so important in the doctor-patient relationship. That for me is very important. I wanted that in my medical career. I saw patients who trusted their oncologists. The thing that I think that struck me the most was, so I did my residency at a public hospital. I did my residency where I'm now an attending, although I took many years off in between to work at other institutions, and now I'm back. There's a lot of patients who don't take the medications they're supposed to. I had one guy who had congestive heart failure, and he would eat an entire chicken, like a chicken or a turkey, an entire turkey, the night he felt he was having a congestive heart failure exacerbation, because he knew he was going to get admitted the next day. So he figured he'd eat a turkey. He already was in an exacerbation, then come into the hospital. And I was like, what is happening? Like, what kind of medicine are we practicing? And oncology was the first field where I was like, wow, these patients actually listen. They actually listen. They do what you ask them to. And it's a team thing. It's not like you tell them what to do. It's you talk about it with them. And cancer's scary. Somebody says you have cancer, it's terrifying. So there's a lot of trust placed in the physician to really help guide the treatment plan, which I didn't see as much in a lot of the other fields, where a lot of people would come in and so I want this medication, I read about this online, I want this, or they wouldn't do what they were supposed to do. And so for me, it was that relationship and then that trust that I felt was still there between the oncologist and the patient. For you, if you're interested in doing peds hemonc, what I would suggest that you shadow a peds hemonc doc or do a rotation with peds hemonc. For me, the reason it's funny you say that, because the reason I said I would never do hemonc is because I saw a bone marrow biopsy of a pediatric patient when I was in medical school. And I was like, this is barbaric. I'm never doing this again. But it turns out it's actually not barbaric. I just didn't know what I was watching because no one had explained it to me. I think that the first thing you need to do is find a peds hemonc doc and shadow them, or ask them if you can go to their clinic and go to their clinic with them for a couple of visits. And then ask them what their path was. I think for peds hemonc, I think you have to do pediatrics first, and then you can do a subspecialty in hem and onc. It's totally doable. You just have to find the path for you. So it's usually a general residency first, and then subspecialty fellowship after that.
Yeah, I'm about to paste a link. I had a discussion with a pediatric oncologist on specialty stories back on episode 38, an actual a med school friend. So you can go listen to that as well.
Very cool.
All right. Thanks, Elise. Let me demote you.
Thanks for the question, Elise.
Yeah, change role to attendee. There we go. All right, Stephen, hello.
Hi, Dr. Jain. Thank you for coming on and speaking with us. My question is, you've been in the field for a few years. I mean, I don't know how many years you've been in the field, but where are some areas for growth that you still think like the field of hematology and oncology needs to grow, or like, what do you see as a necessary change in the next, 5 to 10 years?
So there's a lot of ways, what a great question. There's a lot of ways hematology and oncology can grow. First, I'm going to be more general. I think medicine in general needs to figure out quickly how to provide more equitable care. And hemonc is not an exception to that. Our treatments have advanced so much, and many times they are not accessible or available to people who do not have the resources. So I think that is, in generalities, the first thing we need to find a way to provide equitable care in a better manner. That's number one. Number two, when it comes to hemonc specifically, I think these new therapies, like these immunotherapies, this CAR T cells, I don't know if you've heard about that, all of these different ways that we're finding to cure cancers. I think finding combinations of therapy with chemotherapy and immunotherapy together, finding ways to really amplify the impact and the effects of the treatments we already have to get more people towards cure, but not even just cure, helping people with metastatic cancers thrive and survive and live their lives, I think I could be Dr. Seuss. Getting those patients to really enjoy their lives is really important, because right now there's always been such a focus on prolonging life, which is very important. Prolonging life is absolutely essential. But if you're prolonging life and you're miserable the whole time you're prolonging life, is that really a life that people want to live there? And different people feel differently about that. And that's why it's personalized care when you decide how you're going to provide care. But I think if we can find more ways to help patients with metastatic cancer, not just exist, but live and have a good quality of life, I think that's super important.
Great, thank you very much.
All right. Jules, hello.
Hi, how are you? Thank you so much, Dr. Jain, for talking to us. I kind of have two questions, but they're kind of similar. I wanted to ask, what's something you would have told your pre-med self when you were going through the process? And if it's different, then what the biggest piece of advice you would give to a pre-med student is? I also am wondering that. Thank you.
What a great question. I'm thinking back to my pre-med self. So I'm a horrible test taker. I'm a horrible standardized test taker.
And yet you're still going for that triple board certification.
I am. Well, and that's why I'm doing the longitudinal knowledge assessment now, where I get to do questions every 90 days instead of that long 10-hour exam.
Smart.
Yeah, I'm a horrible test taker. My MCAT scores were abysmal. Like I don't even remember what they were. I just remember I took them multiple times and I feel like I did worse every time I took them. Like they were bad. I would tell my pre-med self that the scores you get on your tests are not even nearly indicative to what you can potentially do as a physician or a clinician. And they are not indicative of what type of doctor you're going to be, nor are they going to be indicative of what type of work you can do and what types of lives you can change. To me, I think that the standardized testing system is nonsense. And I think it's set up in a way that does not, it rewards people who are good test takers. My husband is a phenomenal test taker. We went to med school together. I would study for a week. He would study for 3 hours. He would set the curve and I would pass. Like and he even I tell him, I hope our kids got his test taking skills because I am not a good test taker. Yeah. So I would tell myself, don't sell yourself short. Don't let the tests define who you are. And most importantly, all those people who are telling you you're not going to be a doctor, you'll show them one day. That's what I would tell them, because I had numerous people tell me not even to apply to med school, that I was never going to get in, that it was a waste of a spot. Maybe I should go be a party planner, I had a PI in the lab I worked in, literally tell me you should go be a party planner. I was like, awesome. Thanks for the life advice. I'm not going to be a party planner, although it's a great job. So that's the advice I'd give myself. The advice I would give you all, any pre-med out there. It's really hard to lose the forest. It's really easy to lose the forest for the trees. Oh, I think, the ray of sunshine that's coming in. I don't know how to, we moved into a new house and I have no blinds in my house now. So now I have this lovely light.
Yeah, it's the message from above.
It is a message from above. So for pre-meds today, what I would say is it's a really competitive world out there right now. And a lot of times it's very easy to miss the forest for the trees. That's a phrase, right? Miss the forest for the trees. I have seen so many incredible pre-meds. I've worked with so many incredible pre-meds. All of you, your CVs and your resumes and your accomplishments are way better than what I had done back when I was applying. Remember, as you go through the process, it's going to be hard. You're going to struggle. There's going to be days where you feel like you're not going to succeed. On days like that, I suggest you go to what I call your awesome list. So I've created an awesome list, which is a folder in my email where anytime someone sends me a nice email, or like I have a folder where if patients send me a nice note or a nice message, I keep them there and I look at them. It could even be a message from my mom. I have emails from my parents in there talking about, we're so proud of you. Like literally, when you're feeling like you are at the bottom of the barrel and you're struggling and you're like, I'm never going to do this, go to your awesome list, because everybody has those days. People don't share them with you. I have those days very often. And the reason that I've gotten this far is because 1, I have an awesome list. 2, I have an incredible support system. My parents, my family, my friends, whoever your support system is, go to them when you're feeling that way, because there is so much stress and so much pressure and so much. And social media makes it way worse. You're going to see what everybody else is doing and feel like you're not doing enough. I will tell you, I feel inadequate all the time. Like I go on social media and I'm like, why wasn't I included on that paper? This is my field of study. Why didn't I get invited to give this lecture? Why didn't they invite me for this conference? I mean, I feel that way all the time. Actually, that's not true. I used to feel that way all the time. Now I'm like, thank God they didn't invite me. I don't have time. Oh my God, I'm so tired. I'm glad they didn't ask me to do this paper. What a great job. I'm so glad they're putting this out there. I don't have time to do it. So just remember, we all feel that way. I mean, I feel that way. Just don't let it darken your spirits. Don't let it, dampen your desire to go into medical school. We need all of you. We really do. We need good doctors because we're hemorrhaging them from the healthcare system right now. We need passionate people to come do exactly what is needed, which is take care of our patients and advance medicine.
Yeah. Jules, we'll bring you on for a quick question. What do you got?
Oh, I think I actually just asked that
you
question, but
just
thank you
asked.
so
Yeah,
much.
you're
Thank
welcome.
you.
Forgot to lower your hand. Tricked me. Jessica.
Hi, Dr. Jain. Thank you so much for speaking with us today. I had a question about, I guess, motivation related to what you were talking about. So what were some things that helped motivate you through medical school and residency? And some things that helped, I guess, like help you remember what the goal was?
So what helped motivate me to get me through medical school and residency? Is that what you asked me?
Yeah.
Okay. Honestly, I just knew in my heart of hearts, I wanted to be a doctor. I knew it from the day, like I was 4 years old. I just knew I went through phases in my life where I was like, maybe I'll do this, maybe I'll do that. But I really knew I wanted to be a doctor. And so for me, it was just making sure that everything I was doing was going to get me to that goal. And if I failed, I stood up again. If I failed, I stood up again. If I failed, I stood up again. I got knocked down so many times. Like I could write a book about all the things that have happened to me in my life that I have not shared publicly, and someday maybe I will. It is hard. It is not easy. I'm not going to lie. It's not easy to get into medical school, and it's not easy to get through med school, and it's not easy to get through residency. I would commiserate with other people who were going through the same thing. I would talk to my family, like I said, my support system, but really at the end of the day, you have to want it, and you've got to really realize there's going to be uphill battles sometime, but there's also positives. There's also the rewards that come with it. Like I left every exam convinced I failed, every single one. Like I would call my dad every time and be like, I failed step 1. I failed step 2. Step 3, I think I might have passed that one. But like literally every single exam. And he was like, I'm sure you didn't pass. I'm sure you didn't fail. Did you go back and change your answers? Or did you actually leave your first answer? Like we'd go break it down. And it's so easy to lose sight of what you're aiming for. And it's so easy to get discouraged. Don't let other people talk you out of what you're doing. Don't let yourself talk you out of what you're doing, because don't doubt your ability. Don't doubt your drive. You've got to find it internally. And when you can't find it internally, go to your friends and go to your family and ask them. Be like, am I dumb? Am I doing this because I'm dumb? Like, am I trying to be a doctor? Is this a stupid idea? Like, why am I doing this? And I can guarantee they will come up with 100 reasons why you're not dumb for going down this path.
Dr. Shikha Jain, thank you so much for coming on, sharing lots of positive words of encouragement that I think will carry some people through to the finish line of becoming an attending at some point, maybe. I really appreciate you. You are on Twitter and other social media. Where's the best place for people to follow you?
So I'm most active on Twitter, although right now I haven't been very active because of everything that's been happening. But Twitter, Instagram, LinkedIn, and Facebook. I'm on all of those. You can find me at Shikha Jain MD on any of those platforms. Feel free to reach out anytime. I mean, if you're struggling, if you have questions, my DMs are open. Feel free to message me anytime. I'm really inspired by the next generation, and I really hope that many of you end up being colleagues or maybe you could be my boss someday. Who knows?
Thank you so much, everyone, for coming. Thank you. We had a great turnout today and great questions. We'll see you next time. Bye, Shikha. Thanks.
Bye, Ryan.